Hello everyone, welcome to this episode of a podcast celebrating being released as part of the celebrations of World Field Epidemic 2024. The theme of this year's World Field Epidemic celebrations is collaboration is key to field epidemiology. Today's episode is about HIV pandemic, and with us is Dr. Ario, who is going to talk about the HIV pandemic, give some general review of the pandemic with some contextual information from Uganda, and also we'll talk about his experiences as a field epidemiologist. That's enough for me. I'll give him an opportunity to introduce himself. Dr. Ario.
Thank you so much, Alan. I'm called Dr. Alexis Ario. I am the director of the National Institute of Public Health in Uganda. Before that, I worked in the field of HIV for a long time. And so I was part of the response. The rollout of antiretroviral therapy was actually my direct responsibility. And so I attribute the successes that was recorded in HIV response to some of my efforts and the efforts of many other colleagues that I worked with. Currently, as I mentioned, I'm the head of the National Institute of Public Health, which is a science-based institution of the Ministry of Health and responsible for generating evidence and providing leadership and coordination of critical public health functions to address global health security concerns. And in that, we deal a lot with building capacity of health professionals in the country. And one of the critical cadres that we build capacity in are actually field epidemiologists. And I think the theme of this year's World Field Epidemiology Day fits very well in that context.
Thank you for that answer, Dr. Ario. Let's start with you sharing some lessons you've learned from responding to the HIV pandemic.
Thank you. As I mentioned, as a young officer in the HIV field, as HIV was ravaging the world and Uganda particularly, there are a lot of lessons that Uganda provided to the HIV epidemic. Let me go a little bit back to what it was when we actually started responding to HIV epidemic. You all recall that Uganda's response to HIV epidemic started in the 1980s, and Uganda made significant strides in controlling HIV, and many of them provide insights, to other health challenges that are around the world. So our early response to HIV was marked by President Yoweri Museveni's leadership in openly addressing the epidemic in the late 1980s and early 1990s. Government, of course, promoted a multi-sectoral approach and encouraged open dialogue about HIV and AIDS, which reduced stigma and raised public awareness. And our response at that time heavily relied on community-based organizations, including religious groups and non-governmental organizations. You all recall TASO, yes. The AIDS Information Center, yes. And many others that provided critical support in spreading awareness, providing support and changing risk behaviors, in the country. You also recall the Uganda's ABC, the famous ABC, yes. Abstain, be faithful, use condoms. It was a bold and clear public health message that helped reduce the spread of HIV by promoting behavior change. So open discussions about HIV prevention were key to destigmatizing the disease and encouraging people to seek treatment and testing. And the response in Uganda actually brought together that approach by government for the multi-sectoral approach, brought together different sectors, including Ministry of Health, including education sector, including finance and defense, amongst others, to develop comprehensive and coordinated response. And similarly, it brought on board many international agencies. You all recall UNAIDS, yes. The World Health Organization, the Global Fund, PEPFAR, USAID, USCDC, and many others that played significant roles in supporting Uganda's programs. And the Uganda decentralized health system also provided a very good fertile ground for actually expanding coverage of HIV and increasing testing. Most importantly, many people may not know, is what we rolled out, what we call the integrated management of adult and adolescent illnesses, where we actually train non-doctor prescribers, and that actually changed the trajectory of HIV. We rolled out ART. I remember very well that many of our senior colleagues, doctors, criticized us for doing that, because we, for the first time, we introduced non-doctor prescriptions of ART, but that increased the coverage. Exactly, antiretroviral drugs.
Yes.
And that increased coverage so much, and of course improved the life of the people. And then the other bit of it was the strengthening of the infrastructure and the health system. Because of the heavy investments that we had from USCDC, from PEPFAR, from the Global Fund, we actually improved infrastructure that eventually actually improved the overall essential health service delivery in the country. And then the other thing that provided critical lessons was that we looked at a comprehensive package of HIV. We look at prevention, we look at treatment, we look at care, including psychosocial support. And so that provided a lot. Early detection, provided timely, treatment, and reduced transmission rates. And then destigmatization, worked along the way. So a balanced approach to prevention, treatment, and care was key in reducing both new infections and even AIDS-related deaths. And then the other thing was adapting our response to behavior change campaigns. So a lot that happened was that much as there were behavior change campaigns, we were offering treatment, we also started offering some other biomedical interventions, like male circumcision, if you recall.
Yeah, medical male circumcision.
Exactly. And so we coupled that with, as we expanded ART coverage. So that alone actually strengthened a lot of HIV response. And then we also strengthened our data-driven approaches. Yeah, like the most current one, of course, many people may know, is what we call the Uganda population HIV impact assessment surveys. Yes. So that has provided us data to inform programming and many other things that has happened in the country. So those are some of the examples that I can give in terms of lessons learned from the HIV epidemic in general.
What has the field epidemiology learned through the response to the HIV pandemic?
Now, because as a young officer who has grown up in all this, and also now building the capacity of field epidemiologists, I want to just give a brief background of the evolution of field epidemiology itself in Uganda. The discipline of field epidemiology has evolved significantly and has changed the trajectory of response not only in HIV, but also in public health emergencies and global health security. So we learned a lot as field epidemiologists. We've learned a lot, particularly in response to unique health challenges and the need for effective disease surveillance and outbreak response. Of course, as a country, Uganda has faced numerous public health challenges, including Ebola, malaria, anthrax, name it, and of course, currently Mpox, which we are experiencing. So the necessity of field epidemiology is now eminent. But most importantly is that this field epidemiology that we are talking about started way back in 1994. It was actually launched in Makerere University as a Master of Public Health program. And so it is a long program that has been here, has churned out very many Master of Public Health graduates. But I need to mention that we currently have a program which is running parallel to the original Makerere Public Health Fellowship, Master of Public Health program. And that is what we call the Uganda Public Health Fellowship. Uganda Public Health Fellowship has actually 6 tracks. But the most relevant for our discussion today is the field epidemiology component. So the field epidemiology component, we have what we call the advanced field epidemiology, which is a postmaster's program, which we train professionals. So we build capacity of professionals in actually responding in managing, addressing public health needs in the country, responding to emergencies, and of course also ensuring that our surveillance systems work. So this program started in 2015, okay? And as we talk today, it has actually churned out 93.
93?
Yes, field epidemiologists that are actually working in different sectors within the Ministry of Health, within the national organizations, including Affiliate. Yes, including Affiliate. So this initiative has strengthened disease surveillance system so much in the country. You all know the strategy which is called integrated disease surveillance and response.
Yes.
So that is the cornerstone of surveillance in Uganda. So that has improved detection, tracking, and responding to infectious disease, both at community and national level. So in responding to HIV, we as field epidemiologists, we learned a lot by going beyond the basic case reporting. You remember when HIV started, when not so much was known about HIV.
In the
Exactly. Yes. So there was that case reporting, which eventually informed a response, and then eventually informed everything that happened around HIV. So there was that case reporting. But what we learned is that you need to move away from case reporting, which actually now we are going back to as we brought down the prevalence of HIV. But we learned a lot that you need to combine many things, including sexual behaviors, including how do you get the overall picture of HIV, of the epidemic. So when we set up sentinel surveillance systems, that helped actually shape the way we do surveillance. And so we learned that you can actually set up a surveillance system in HIV, but now we are using it in influenza, we're using it in black water fever, we're using it in many other things. So that's a lesson we learned from HIV. From HIV, we learned that you can actually develop protocols for response, and that we've done a lot. We have successfully managed many of the epidemics from our experience in HIV. Yeah, so we've done all that. We've also learned that collaborating with the international community, with the other agencies, exactly, in a multi-sectoral approach in response, which we learned from HIV, has helped us a lot in global health security. So now we are coordinating with many, organizations, and we've learned that these partnerships enhance sharing of epidemiological data, resources, and best practices, across borders. And so global health collaboration has become the cornerstone of managing epidemics, as you all know, because they require coordinated efforts. And so we are responding. We in our response with Africa CDC, with WHO, with the Global Fund, World Bank mentioned it. We were able actually to address COVID-19 and even the recent Ebola, and now we are addressing mpox using similar methods. So of course, as the country continues to move, we are also facing the scourge of non-communicable diseases. We learned this from HIV. When we learned about the relationship between HIV and non-communicable diseases, these are something which is not new to us. So we learned a lot from that, and we know that actually non-communicable diseases can complicate HIV. Infectious disease. Exactly. And so, and the other way around.
Oh, so infectious disease can complicate.
Exactly. Can actually, we have infectious diseases that can eventually actually lead you to develop non-communicable diseases.
Yes.
Yeah. So this interface, we learned a lot of it from HIV. We had a lot of documentations that we've done in HIV. And then, of course, the other bit of it also was the bit of shift from the biomedical approach to obtaining biological data in HIV, but also the sociological approach. So that sociological approach, which we learned in HIV, is actually helping us in response now. So we know that actually when you are responding to a public health emergency, sending only field epidemiologists without a social worker or an anthropologist leaves a gap.
Yes.
Exactly, leaves a gap. So those are some of the things we learned.
So it's not just technical people, you people who understand.
Exactly, the community of the community. You need to understand the aspects of the community. Otherwise, in fact, one of the critical disease conditions, I can give an example, is anthrax. People wonder why we've talked about anthrax. When you have an animal which has died suddenly, please don't eat. But we've had communities where an animal dies, they know, but they still go ahead and eat the animal. Exactly. So using that approach, we've actually done a lot of CAP studies to understand why communities do this. And that has helped us a lot now to address it from the community perspective. Yes, not just from the technical AP perspective.
Yes.
Exactly. So all these, then other things that we learned from HIV is SMS medicine. You remember SMS messages for adherence,
Yes.
where you'd send alerts
Alerts
for
to
adherence. Now we moved away from using that SMS now in response. You heard about the MTRAP.
Yes, I about that.
Exactly. You heard about the community sending messages and then we receive alerts from the Emergency Operations Center.
Yes.
Exactly. So we are doing that in receiving alerts.
Yes.
For general public health emergency, you heard about the event-based surveillance.
Yeah.
So we use SMS. We're also using SMS for reporting mortality.
Oh,
Exactly. So we're improving mortality surveillance using SMS. Yeah. So these are all things that we learned from HIV. Then the other thing is about the stigma.
Yes.
Exactly. HIV brought into light the devastating effects of stigma. And we learned a lot about that you can actually fight stigma from HIV. In the recent COVID-19, typical example of where there was a lot of stigma among the patients that suffered from COVID. We all brought in on board lessons that we learned from
HIV.
Exactly, from HIV. Exactly. Yeah, then one other thing also which we learned about HIV is actually precision targeted interventions. Because now, that is exactly where now we are looking at. We are now looking at key populations, okay? And so key populations that we are looking at has helped us.
So those who are most at risk.
Exactly. So you address it from the most at-risk populations. And then you target and control. Because that's actually what we talk about now. If you hear about us targeting, controlling outbreaks at source.
Yes.
Where it occurs, we want to stop it there.
Yes.
And that's exactly what we learned from HIV. Addressing from the key populations. So stop it where it is.
It is, yes.
So that it doesn't go outside.
Spread out.
Exactly, spread outside. Then one other critical thing that we learned, remember when we used to prepare a lot of these data that I'm talking about, which inform policy decisions, and a lot of changes in HIV. We've actually generated studies, results from studies, epi-studies, outbreak investigations, surveillance data analysis or evaluations, and all that has informed development of policy briefs. And these policy briefs has informed policy decisions.
Can we move on to talking about how the role of field epidemiologists in responding to HIV has evolved over time?
Okay, yeah. Now, so when field epidemiologists, like when I got trained as a field epidemiologist, that was when HIV was at its peak. Actually, it was the time it was now beginning to come down, but it was coupled with a lot of messages which are coming in. So a lot actually was done. But I've also seen what has happened along the way. How we've responded to HIV itself, how we've responded to similar conditions, similar epidemics and pandemics. And so what I can say comfortably is that field epidemiology has played a pivotal role in HIV epidemic. Particularly in understanding the transmission dynamics, tracking the spread of the disease, and of course in informing public health interventions. But over time it has evolved. Because remember, we had all these people dying, which we didn't have medicines. So medicines came. ART became a game changer. And so, but a lot happened in between to understanding what was going on, including determining which interventions were effective. Now, these are all things which field epidemiologists did. And so, in the early stages of the infection, as I stated earlier on, was the case identification, where you go and identify the cases and then, see what the problem is and look at what are the drivers of the epidemic. So that happened a lot in the initial stages. Exactly. And that, of course, informed surveillance. And then the design of intervention or prevention strategies. Because initially when we didn't have medicine, it was basically prevention. How do you design prevention messages? You need to understand what you're talking about.
And how to be received.
Exactly. So you need to go to the community, you need to get the views of the community, you need to get the myths, perceptions, and then see how you take back these messages. So the information that was generated by field epidemiologists helped a lot in designing HIV prevention strategies. And then, of course, the behavioral change. A lot about behavioral surveillance was done, and that helped shape behavioral dynamics within the communities, and then how they relate to each other, and then also how they relate with, with the patient at community level. And then come treatment itself. When ART came, a lot of course happened. From the single dose, and then to
the multiple pills.
The multiple pills, and now we are going back. Exactly, we are going back even to single injections, and that seems to be working. And all this happened with a lot of studies which were done. The combination of field epidemiologists and of course other researchers, because field epidemiology gets you all this data from the community perspective. And so a lot was done around that, designing these strategies. And then, of course, going back to what I talked about was dual infections. Yes. Dual infections of having...
you have HIV.
You have hepatitis, you have TB, you have STI, you have all these things here. You need to understand the dynamics.
Yes.
Exactly. Because some of them are occurring singly in patients, but some of them are occurring in form of epidemics, what we call syndemics.
Oh, okay, syndemics.
Yeah, so you can have a dual epidemic occurring at the same time, not just one.
Not just one.
Exactly.
Two going on.
Exactly, as an epidemic. So these are things that field epidemiologists do regularly to actually inform HIV response. Then, of course, the other one is monitoring trends. Yes. Trends of treatment, trends of response, to side effects.
Or what is more prominent in media is trends of infection.
Exactly, all that. So all those things, the trends that we monitor, helped a lot in informing how we program. How do we target? How do we inform, like the AIDS control program, to forecast, to project on how much medicine will be needed. Exactly, will be needed and all that. Exactly. So they need this information. Then the other one, as I mentioned earlier, was about the policy group, providing leadership. This is something that field epidemiologists learn. They are built up as public health leaders.
Yes.
So they have provided leadership in HIV, and we have actually seen this happen. We've seen this happen where you realize many of the leaders now in AFNet, in UNAIDS, in WHO, in Africa CDC, within PEPFAR itself, in the US CDC, they are field epidemiologists.
Yes,
because of the leadership skills that they have learned along the way. Yeah. So for me, in conclusion, the role of field epidemiologists is responding to the HIV epidemic has evolved from basic case identification to surveillance and to leading global health initiatives and developing complex integrated responses. So we've done that as field epidemiologists. And so our contribution have been critical in understanding the HIV dynamics, shaping prevention and treatment programs,
yes,
and of course, adapting to the changing landscape of HIV. So the lessons learned and skills developed during the HIV response continue to inform the broader public health efforts to tackle infectious diseases in general and health crises as we move along in the contemporary world.
Just to re-emphasize, what we're learning from HIV, we're applying to epidemics.
Exactly, we've learned a lot from that, and we're actually applying. Because now in the global health security arena, it's a lot that we have actually learned, and we are applying to ensure that we actually address the critical components of critical areas that address global health security, but also address compliance to international health regulations, which is a requirement, and Uganda is a signatory.
Thank you for that informative and very comprehensive explanation and also discussion of what we have learned about HIV in Uganda, and your experience. Thank you, Dr. Ario, for talking to us about the HIV in Uganda and how the pandemic has evolved, and also your experiences as a field epidemiologist responding to the HIV pandemic